misconception that little can be done about stillbirths. In fact, the majority of stillbirths are preventable with quality care during pregnancy and at the time of birth. We have seen over and over again how sound policies, programs, and investment make a difference. Countries at all income levels have seen substantial progress, even in settings with many challenges. 14 countries, including 3 low and lower middle income countries, Cambodia, India, Mongolia, have cut their stillbirth rate by more than half over the last 20 years. But this progress is threatened by the COVID-19 pandemic. Now is the time to redouble our efforts, and we must not let up. We need to increase investments in maternal and newborn health, improve infection prevention and control practices, and better organize care and referral pathways. It's important that all countries set a stillbirth reduction target to focus their investments and efforts. We must also improve the measurement of stillbirths to give us the data needed for programming and investment. Finally, and very importantly, we must work to reduce the stigma and misconception around stillbirths. No woman or family's grief should be hidden due to stigma. They need support, not shame. Improving care and ending preventable stillbirths is possible. I thank you.
Thank you very much, Dr. Tedros. As you're joining us, as you're joining this Ending Preventable Stillbirth session, I'm looking at some of the comments that you're sharing with each other. Frank Akadi, for
General of the World Health.
Great to be part of this important topic. Thanks to UNICEF and other partners for giving it the necessary attention. A much needed conversation. Dr. Nina Rayner, finally, there is attention to this important area, which we at WHO Zero have been focusing on for the past decade through web-based surveillance. More of your comments, more of your questions to come. But first, I want to go to the Nigerian Minister of Health, Dr. Osajay Ehanire. Welcome to our conversation.
General of the World Health Organization, Dr. Tedros Ghebreyesus, the Executive Director of UNICEF, Mrs. Henrietta Fore, and other members of the UNICEF group, Dr. Katie Allen, member of the Australian Parliament, Dr. Anshu Banerjee, Director, Department of Maternal, Newborn, Child and Adolescent Health and Aging, Mrs. Akin Toyin Oyeleye, Nigerian parent, Dr. Gutai Yakubi, Acting Director of RMNCAH Afghanistan, Dr. Amy Polak, Bill and Melinda Gates Foundation. I am honored and delighted to welcome you all to this important technical meeting with the theme Ending Preventable Stillbirths, a renewed call for action, which is intended to raise awareness and amplify our voices in a call for renewed commitment to end preventable stillbirths. I thank everyone for taking out time for this great work and the focus on the voiceless ones, the stillborn. The need for awareness of stillbirths in Nigeria cannot be overemphasized, given the burden neonatal health lays on our health system. Stillbirths have been overlooked as a global public health challenge, in spite of the fact that useful preventive measures could easily augment maternal and newborn health initiatives to limit incidence. Taboos and vary with cultural settings are a sensitive indicator of quality of care in pregnancy and at delivery. A lot more needs to be done to capture the actual conditions around them. Nigeria, unhappily, has the second highest rate of stillbirths in the world, with 42.9 per thousand births, as well as the second highest absolute number of stillbirths, estimated at 340,000 in 2015. The government set a target of reducing it to 27 per thousand live births by 2030. The government of Nigeria is committed to realizing universal health coverage, leaving no one behind, and to improving the health of women and children, quality reproductive, maternal, newborn, and adolescent child health, plus nutrition services, particularly at primary healthcare levels. It requires a multi-pronged approach and multi-sectoral collaboration. As part of a renewed commitment to reverse unacceptably high maternal and newborn deaths and stillbirths, we recently launched a new multi-stakeholder coordination platform to strengthen partnership, leverage additional resources, and harmonize efforts to maximize impact on technical reproductive, maternal, newborn, child, adolescent, and elderly health and nutrition delivery. The partnership is multidisciplinary and multisectoral and includes the education sector, whose role relates to health-seeking behavior of women and adolescents. Evidence has shown that educated women of reproductive age are more likely to access health and family planning services, antenatal care, delivery by skilled health attendants, and so reduce risks of maternal mortality and stillbirths. We have concluded various interventions that directly and indirectly address perinatal and stillbirth challenges, such as the Nigerian Every Newborn Action Plan, the Saving 1 Million Lives Performance for Results, the Midwife Service Scheme, the Meeting Family Planning Commitments, Improving Access to Antenatal Care, the National Malaria Elimination Program, and the increased domestic funding by operationalizing the Basic Healthcare Provision Fund access to a basic minimum package of health services to poor and vulnerable women, children, adolescents, and the elderly in rural settings, where disproportionately high incidence of largely unreported births and stillbirths occur. Operationalization of the National Emergency Medical Service and Ambulance System, NEMSAS, which assures access to care at no out-of-pocket cost at point of care. NEMSAS offers emergency obstetrics care by providing first aid and ambulance transportation to overcome access related barriers, especially at odd hours of the day or at hard-to-reach areas. We recognize the stigma around stillbirths and their recording in communities and health facilities. To strengthen the National Health Information Management System, we use various platforms to track performance and progress, use evidence for decision-making, and ensure accountability by including scorecards and a family planning dashboard. I must here commend our partners for bringing the first report and estimates on stillbirths to light, a bold step that builds the capacity to generate, record, and report stillbirths and overcome the tendency to underreport. More importantly, however, it supports a positive attitude and initiatives to prevent stillbirths. To conclude, I urge participants to contribute and come up with a smart roadmap for ending preventable stillbirths in our world. I thank you all for your attention.
Thank you very much, Minister. We appreciate your thoughts there and honesty and being very candid about where Nigeria is right now when it comes to preventable stillbirths. We will talk more about Nigeria and some other countries coming up a little bit later in the conversation. But I know there are two questions that are on our minds right now. One is, what is the current situation regarding preventable stillbirths globally? Two is, what can we do about it? I have two perfect doctors to help set the scene. Dr. Mark Herod, Dr. Anishu Banji. Dr. Anishu Banji is from the World Health Organization. Dr. Mark Herod is from UNICEF. Together, this is collective, renewable action. So we're going to start with Mark. Mark, what do you want to tell us?
Thanks so much, Femi. Thanks for that great introduction. And I also want to thank and draw attention to the fact that there are 21 other organizations who are all joining together for this event. And that is the kind of partnership that we need to be able to make a difference in this sad and unnecessary tragedy. And I want to thank all of the panelists and participants for joining us today. I'm pleased to be with you to discuss the current burden, the progress, and the gaps in ending preventable stillbirths. On October the 8th, the UN Interagency Group on Child Mortality Estimation, UNIGME, released the first ever joint UN stillbirth estimates and report. The release of the stillbirth estimates and report is a critical milestone to enhance the availability of data globally and to drive political and public recognition of this neglected issue and tragedy. Rigorous estimation for stillbirth rates is critical. Many countries have poor availability or poor quality of data. Among the 195 countries for which we aim to generate stillbirth estimates, nearly a third, 31%, which is 62 countries, have no stillbirth data or have data quality problems. Many of these countries are in situations of high burden, such as many countries in sub-Saharan Africa. 44% of all of the countries with this problem are from there, or in low and lower middle income country settings, over 40% of the countries with data issues. So evidence, investment for evidence and for data collection is particularly critical in those settings. Identifying stillbirths, strengthening data collection systems, and improving data quality are key to filling these enormous data gaps. With the UNIGME estimates, we can begin to understand better the magnitude of the stillbirth problem. How many babies were stillborn in the past 2 decades? 48 million. In recent years, nearly 2 million stillbirths occur every year. That's 1 every 16 seconds. Over 400 babies could be stillborn during the course of our event today. And these are not just numbers, these are lives lost. They're mothers and families who face this tragedy every day. And why are these numbers so large? Why are these unnecessary stillbirths still occurring? Why are stillbirths unseen, unrecognized, uncounted, and unprioritized? Social taboos, stigma, misconceptions surrounding stillbirth, and exclusion from policies and programs mask stillbirths from receiving their needed attention and investments. And they mask the pain and the costs experienced by families. And stillbirths are not experienced equally across the world. There's up to 23-fold difference in stillbirth rates between countries. Mothers in sub-Saharan Africa and in Southern Asia bear the heaviest risks and burden. 3/4 of all stillbirths globally occur in those two regions. In sub-Saharan Africa, where births are rising fast every year, 1 in 46 babies is stillborn. So much higher than 1 in 321 babies in Europe, North America, Australia, and New Zealand. Globally, the stillbirth rate has declined by 35% since the year 2000. But the progress in reducing the stillbirth rate is still slower than that of child mortality. To be precise, the annual rate of reduction in stillbirths, 2.3%, is much lower than the annual rate of reduction for under 5 mortality, which is at 3.7%. And there was no acceleration in progress of reducing the stillbirth rate in the 2010s at 17% reduction compared to the 2000s and 19% reduction. So, as progress in reducing child mortality around the world continues, stillbirths are at risk of being left behind. In the year 2000, stillbirths accounted for less than a quarter of the share of combined stillbirths and under 5 deaths. That's 23%. But that had increased to over a third, 36% in 2019. And of course, the COVID-19 pandemic could further slow the progress in ending preventable stillbirths and could even add to the burden this year. An additional 200,000 stillbirths could occur in 117 low and middle income countries in a 12-month period due to severe disruptions in critical health services, with 13 countries that could see an increase of more than 20%, of more than 20%. However, we were missing opportunities to prevent families from experiencing the pain of stillbirths even before the pandemic. In half of countries analyzed, less than 2 to 50% of pregnant women received key interventions that could prevent stillbirths. So now let's make it clear. As the Director General was pointing out, progress is possible with sound policy, investment and programs. Southern Asia, which has the second highest stillbirth rate of all regions in the world, has reduced the stillbirth rate by 44% since 2000. And 14 countries, as the Director General mentioned, including 3 low and lower middle income countries, Cambodia, India, and Mongolia, reduced the rate by more than half in the past 2 decades, suggesting progress is possible, even in a resource-limited setting. And importantly, most stillbirths are preventable with life-saving interventions and high-quality care. Over 40% of stillbirths occur during labor and could be avoided with improved monitoring and timely access to emergency obstetric care when required. Without urgent action and accelerated progress, 20 million babies will be stillborn by 2030. 56 countries are at risk of missing the target of a rate of 12 stillbirths or fewer per 1,000 total births by 2030. More than half of them will not even achieve that target by 2050. It is unacceptable that millions of mothers and families will experience the pain of stillbirth due to inaction or lack of investment. We must do better, we must work faster, and we have to have a renewed commitment to end preventable stillbirths. Thank you. Thank you for your attention. It's now my great honor to pass the floor to Dr. Anshu Banerjee.
Thanks, Mark. Thanks a lot. And I wanted to pick up on your last slide where you highlight that 56 ENAP countries are not on track to achieve their targets. Next slide. Because if we look at the global data, we see actually that the stillbirth rate at the moment is 13.9 and our target is 12. But next slide. But this really highlights the disparities between the different regions. And so globally, maybe it looks as if we are going to achieve the target of 12 per 100,000 or per 1,000 live births. Individual countries or many individual countries are not going to be able to achieve that. And so here we see that in a couple of regions, for example, in the African region, not a single country actually has already reached the target of 12. And if we look at some of the high-income countries, we see that all of them have already achieved it. So there's wide disparity between regions, but also there is wide disparity within regions And this is exactly the reason why we are coming out with this renewed call for action, in order to really highlight that every newborn child should have the same chances at the beginning of life, and every pregnant mother should have the chance to have an equal chance to have a healthy newborn. Most of the services can be actually, as Mark already alluded to, are quite are cost effective and can be provided in an integrated manner. And so why have we linked the newborn agenda together with the stillbirth agenda within the Every Newborn Action Plan? And this is because there's so much overlap between the two areas, the two agendas, and the interventions that need to be provided to prevent both stillbirth as well as to have a healthy newborn, and to also have a healthy pregnancy, positive experience. First of all, healthy newborns require healthy mothers. They need to have a period that is healthy within the utero and as well within the postnatal period. So the environments there have to be conducive. And newborn health is also strongly dependent upon maternal health and in utero health. So dying before birth is really the ultimate adverse newborn outcome. And we really would like to prevent these adverse outcomes. Also, the causes for stillbirths and for newborn deaths there's a lot of overlap between them. So, for example, the maternal conditions that are affecting placenta or fetal growth both have an impact on ending up in a stillbirth, as well as for the newborn ending up with, let's say, an unhealthy start at life. We know that infections play a major role, such as syphilis and group B streptococcal infection. We have interpartum obstetrical complications that could result in a stillbirth, or potentially in a newborn that is flat, that is not healthy when it's born and die soon after birth. We could have complications due to antepartum hemorrhage and also due to congenital and genetic conditions. And these are all causes for mortality for both stillbirths as well as for newborn mortality. So for this reason, we would like to make sure that progress could be accelerated. Progress so far has not been fast enough. And this is because a number of systems issues haven't been addressed. We know that we have set ENAP milestones, but we know that from the 93 countries that have reported last year, that 42 of them do have guidelines and an implementation plan, but that's only 42%. 43 have a human resource plan, 53 have a policy to audit perinatal deaths, and 44 have a research agenda. But clearly, more than half in most of these milestones, more than half of the countries have actually not yet put in place the systems building blocks to really address this agenda. And besides that, what is also very important is that we maintain trust in the health system. And therefore, the Lancet series in 2016 also highlighted that we need to have a package for respectful bereavement care after death in pregnancy or childbirth for the affected family, for the community, and also for the caregivers. Because often also the caregivers experience blame, and also it's emotionally difficult for them if they have a stillbirth during the delivery. So it's important for us to reduce stigma, to make this issue discussable, put it on the table, and look at how we can reduce stigma and be able to address these systems issues that need to both support the bereavement, but also the prevention of these preventable stillbirths. So for that, the renewed call to action is a 5-point agenda. The first one is around raising voices and increasing awareness, reducing stigma, taboo, and misconception. The second one is around support bereaved women and families and communities. Thirdly, we would like to strengthen health systems to provide high quality of care, achieving equity in every country and region through sustained investment. Fourth, to set national and subnational stillbirth reduction targets, and fifth, to improve measurement of stillbirths to enhance evidence and knowledge. So for the first one, it's really about how we improve understanding of stigma associated with stillbirth, and also looking at awareness of the impact and preventability of stillbirth. Once again, we would like to highlight here that 2/3 of stillbirths are preventable through very low cost effective interventions. It's also going to look at continued advocacy to ensure that stillbirths are included in all maternal newborn health reports, in policies, in research, and in programs. And we would really like to raise the voices of parents and health workers. And we're going to have panels around this later. Second action area is around how we can support bereavement for women, their families, the community, and for health workers as well. And so each stillbirth is an individual and painful story associated with significant direct, indirect, and intangible costs for women, families, the society, and healthcare workers. And we'd really like to make sure that we can address the grief that is associated with stillbirth, which is complex and unique because of the stigma, the blame, lack of legitimization of grieving processes in society, and its profound effect on families and also on healthcare workers. The third action area is really around health systems and around universal health coverage. And we want to make sure that the interventions need to be part of universal healthcare packages, that everyone has access to that, and that we also address inequities. And for that, we'd like to focus on access to quality, respectful care for every mother and newborn, because services that are provided without quality are often a waste of the intervention. And also that the strengthening health systems to deliver high quality, respectful care for mothers and newborn everywhere is especially focusing on antenatal, interpartum care, and also care after death. And for that, within ENAP, we have set targets. We have set targets both at the global level, at the national level, and at the subnational level, because we really want countries to be able to measure where they are and to be able to take action on the findings, and to be able to look at inequities between regions, between districts, between provinces at the subnational level, in order to be able to target their interventions and their investments to have maximum impact. And at the same time, we have set milestones that address really the health systems issues, and that highlight not only the interventions that are needed and need to be supported through these health systems interventions for newborn mortality reduction, but also for the prevention of stillbirths, and it is highlighted throughout. The fourth action is around setting targets. We know that of the 93 countries, that only 30 actually have set a stillbirth target. And we feel that with this call to action, we would really like to request countries to set that all of them should set a target for stillbirth reduction. At the moment, only 8 of the 20 highest mortality countries, the countries with most of the cases, have actually set a target. And at the same time, the 20 countries with the highest rates, we know that only 8 of them have set a target. So this would really be a call for us and a priority action for us, that all countries set a stillbirth target, reduction target. And finally, we should support countries in measuring this. So it's important that countries can capture the stillbirth in all relevant data platforms, that we should be able to also understand and improve the understanding of the causes of death, and that we make sure that the data that are there are data of quality, that are owned and can be used locally to drive action. Thank you.
Anshu, Mark, thank you very much. Attendees, you would have noticed there's no Q&A box, but we're in a conversation, so it makes sense for the conversation to be in the chat box. So I have been monitoring it. We've been looking at it. All of those slides that Anshu and that Mark shared, they will be available later. Let's get started with the questions. Peter says, we should remember that healthcare workers also need programs to support them as they are affected by loss of life. Anshu, Mark, who wants to take that one?
So thanks. And I think that was the point that we wanted to raise as well and highlight. And I think there are several issues here. First of all, the healthcare workers, of course, it's emotionally difficult for them as well that they have assisted a mother in delivering a stillbirth, basically. They have to engage with the mother as well. They have to provide emotional support to the mother and the family. But for themselves, it is also a traumatic experience. This is at the moment itself of the stillbirth. But afterwards, once we have perinatal audits, we need to be careful that we don't blame the health workers. The perinatal audits looking at why deaths have happened need to be constructive. They need to lead to positive action that actually reduces the number of stillbirths. And for that, we need to make sure that we don't have a blaming attitude. We don't blame healthcare workers, but we look at why these stillbirths happened in a constructive manner in order to ensure that future action will reduce further stillbirths.
Let me go to another question. Mark, I hope you don't mind taking this one. This is from Danielle. How does stigma impact dissemination of resources and education surrounding stillbirth?
Thanks so much. And it's the issue of stigma is really important. It's important, even what Anshu was saying yesterday, that if at the moment the stigma means that a lot of the time the mother herself will be blamed for a stillbirth happening. That she will maybe be blaming herself or be blamed by others for being inadequate in some way, and that's why the stillbirth happened. And it's very important, as Anshu was saying, that blame doesn't get transferred to the health worker either. But there's a constructive way of approaching the reduction of likelihood of stillbirth, as well as the way that we deal with them. So the stigma means that the resources are not put in the right place because the mechanism for understanding what has gone on and why a stillbirth has tragically occurred is obfuscated by the assumptions that people are making. And the blame being wrongly assigned. So it's really important to be able to get to a place in each community where the issue can be addressed for what it really is, rather than for what it's assumed to be. And that's the main thing we need to do by getting over the stigma.
All right, next question. This one is from Olufemi. There is need to explore so-called intrapartum stillbirths during pregnancy and delivery. Tools to easily measure quality of care is of importance, as well as making statistics visible. Anshu.
So, and that's a follow-up question, I think, to what Mark was just saying as well on the stigma. If we don't address the stigma, we don't make stillbirths visible. And if we don't make stillbirths visible, we'll not invest and allocate resources towards that. So I think that's an important issue. Now, around interpartum stillbirths, there are many interventions, cost-effective interventions that we can put in place. For example, during antenatal care, screening mothers for hypertension, screening mothers for high blood sugar levels and potential gestational diabetes. These are cost-effective interventions that we need to put in place to prevent stillbirths. And so making, I think, the issue visible is important in order to strengthen quality of care during antenatal care and interpartum care. So it's just following up, I think, on the issue of stigma. If we don't make it visible, we will not invest. I think our call to action is we need to make this visible. We need to put it on the table. We need to support the families so that they also have trust in the health system when they, for the next pregnancy, for the next time the mother comes to the facility, and can be ensured that we have reinvested in healthcare to make sure that next time she will have a safe delivery, and a healthy baby.
Mark, this is such a good question from Dr. Ghosh. We need a uniform and standard definition of stillbirth for quality and comparable data. In that one sentence, there's so much in there about what is a stillbirth. Is it even counted? Mark?
Yes, it's absolutely right, and it's part of what keeps a kind of a shroud of unknowing over this tragic event, is that people have different ways of defining stillbirth, and you know, how many weeks, and you know, what kinds of conditions surrounding it, and so. Again, you know, what we were doing with this report that we all put together is lifting the curtain on part of the attitudes and the overlooking of stillbirth that we need to take all the way down to the community level. And in doing that, indeed, we find that which is not unusual. Different countries, different cultures have had different ways of defining or viewing stillbirth before, and while those obviously have you know, very strong validity, that's why they were developed that way. We also need to be able to come to an international agreement on what we're going to measure for when we're making these international comparisons, to be able to see, oh, okay, this country is making more than expected progress. What is it that they're doing that other countries can learn from, and so on. So we need that internationally comparable way, you know, agreement and definition and way of measuring stillbirths, while still keeping the culturally appropriate and specific nuances that are needed for different kinds of cultures and the way that they approach life and birth.
Anshu, Susanna asks, where are the blockages against integrating stillbirths into maternal newborn health care?
So I think we try to highlight that actually this is one agenda, preventing maternal mortality, preventing stillbirths, and preventing newborn mortality. So much of it happens either during the day of the birth, so much of it can be prevented during proper antenatal care, but this is one agenda. We cannot separate the two from, or the three issues from each other, basically. And therefore, it's so important, I think, that we make stillbirths a visible agenda item in our policy discussions, in our policy dialogues with ministries, that we have the advocacy around this in order to really make sure that this is one agenda. We want to make sure that preventable stillbirths are prevented, and that, you know, every mother has the same chance globally throughout in every country to have a safe delivery and a healthy baby.
I want to bring in this question from Mrs. Sandhya Singh. This one is going to be for you, Mark. Can you share the best questions in collection of stillbirth data? Actually, you might want to do this one together, Mark and Anshu. Any innovative surveys that you've seen? What can be done to improve data quality? Mark, you start, and then Anshu, you may have some more to add.
Thank you. Yes, as you're probably guessing, I'm going to speak in rather more general terms, and Anshu might well have a much better answer in terms of specifics, like, you know, the questions asked and so on. But in general, what we need to push for most is that at the community level and above, the stillbirths are recognized and recorded. There are other ways of trying to collect this information. There are more indirect ways, but if the information is being collected at the community level, it is ready for action in a small and fast feedback loop. And, you know, as much as it can be reported up and recorded and standardized and published internationally, that's also important. But the first thing is to make sure that data are being used as close to the action as possible, because that's the shortest feedback loop and that's the quickest way that we can make progress. Of course, it has to be part of a national plan. It has to be part of you know, an overall strategy, and so there are other layers above. But I would concentrate more on the fact that we need to be building these systems at community and district level, as the key to making actionable data.
Anshu, I'm going to get the final question to you. I'm not going to ask you to build on the question I gave to Mark. And this one is from Dr. Tinkari. And Dr. Tinkari says, do we have data that countries have made progress? It's a good point to end on.
There was a lot of echo there. Could you repeat?
Yes. Can anybody who's not Anshu close their microphone? And that will solve the problem. Thank you, everybody. So Dr. Tinkari says, do we have data that countries have made progress? Good point to end on. Hopefully, if there has been progress, what can you tell us?
No, we have countries that have made progress, and that's why we're saying progress is possible. And we know that out of the 14 countries that have sort of halved their stillbirth rates over the last couple of years, 3 actually are from low-income countries. So definitely it is possible to make progress, definitely. And that's why we are saying this is preventable. And it is coming back to, you know, having the policy buy-in at the highest level to make sure that systems can deliver, to make sure that the interventions, the cost-effective interventions that we have highlighted are being put in place and are supported. So there shouldn't be stockouts of supplies in order to provide adequate antenatal care or good intrapartum care. The healthcare workforce needs to be there. We should invest in quality healthcare workforce. We should make sure that that data are available to take action. So just the bottom line again is it's possible to make progress. Countries have done it, including low-income countries.
Mm-hmm. Dr. Mark Herowitz from UNICEF, Dr. Anshu Banerjee from the WHO. Your Q&A could go on for another hour, but I'm not going to let it, right? Because we could talk about this for a very long time. Thank you for everybody who shared their questions, their comments. It's not over yet. The chat box is yours for the next 90 minutes. So use it for all the speakers that we have coming up. But for now, Mark and Anshu, thank you very much. We really appreciate you.
Thanks a lot, Femi.
Oh, goodness, we have been talking about stillbirths and prevention of stillbirths and stats and data. And Lou Pearson says, remember, I saw her say this on the chat, that these are humans, these are not stats. And we didn't want to just say it, we wanted you to hear it. So there are a few people I need you to meet. I need you to meet Christine. Christine is in Kenya. Christine, unmute yourself and make your video available and tell everybody who you are, Christine. Go ahead.
Hello, good afternoon, everybody. My name is Christine Wangeshi from Kenya. I am an accountant by profession and a mom of 2 11-year-old sons and an angel who passed on last year, September 2019.
Christine, yes. I cannot say enough thanks to you for being here. We're going to hear more from you in just a moment. I'm hoping to go to Nigeria, and I know it's a little tricky sometimes with connectivity, but I'm wondering, do we have Akindoyin there? Hello. I'm hoping. I see you. I'm not sure that I'm going to hear you. Go ahead, greet everybody. Tell everybody who you are. We see you, but we don't hear you. All right, so what I'm going to suggest you do in the chat box, I'm going to suggest you put in comments and your thoughts so that at least we can have them in this conversation, because unfortunately we can't hear you. But what you have to say is so important. Mr. Akindoyin also lost a child. Her child was stillborn. So I'm going to ask you, this is uncomfortable, but I'm going to ask you if you could type in the chat box and I will share some of those comments, all of them, with our audience. All right, do the one that says all panelists, all attendees, and do that. I want to also bring in Hilma. Hello, Hilma. Tell everybody who you are. A little bit of a gap. Unmute yourself. Make your video visible.
Good morning, good afternoon, and
hello.
Good evening.
Nice to see you. Hi.
I am Hilma Shikwapi.
Hilma, tell everybody who you are.
Okay, yes, I'm Hilma Shikwapi. Yeah. Yes, I'm a midwife from Namibia and also a representative of Anglophone for ICM. Mm-hmm. It's a board member.
Great. And Isti, so Hilma is in Namibia, Isti is in Indonesia. Isti, tell everybody who you are.
Yes, good morning, good afternoon, good evening. I'm Isti Yani. I'm a midwife from Indonesia, currently working for Jepaigo.
We also have a surprise guest, but I want it to stay a surprise guest. Diana, you're the surprise guest. She's coming up in a little bit, but I want you to be as surprised as I was with how I met Diana. Let's start with Christine though. Christine, if you don't feel like you want to share anything, that is your prerogative. You share what you want to share. So you said you lost an angel last year. When did that happen? What happened?
Okay, the angel passed on last year, 22nd of September. That was due to preeclampsia. I had some high blood pressure that developed from week 28, but the pregnancy was stable until week 30 when the highest reading was 168 and over 107. And that unfortunately had affected also the growth of the baby, which had been declining by, yeah.
Nobody asks it's rare to ask what that experience is like to carry a baby and then to lose your baby. How did your family react? How did your friends react?
Okay, usually at the first instance, everybody is in denial, including the mom. But as we progress, it hits home and it really gets to your head that you've lost your baby. It's usually a shattering moment for the family because everybody was expectant to have this baby. The 11-year-old boy was also waiting for the brother. The father was also waiting for these angels. So it's usually a shattering moment for all the members of the family. But by the grace of God, support gets through and we're able to hold our heads high through the season.
I was wondering how you were reacting to the earlier conversation where we were talking about strategies to end preventable stillbirths and figures, and what was going through your head when you were listening to that?
Okay, it's alarming to check at almost 2 million babies are lost every year. But what really gets into my mind is we need to create an awareness for the stillbirth and especially for the pregnant moms. Because I want to believe, especially in Africa, it's almost a taboo to talk about the whole thing. And everybody would almost think it's a bad omen, even as much as when you know it's a health condition that caused the death, you still feel stigmatized and also you feel separated from the world as you try to grumble around the grief and the loss. So the numbers are alarming, but the strategies and the policies in place, we hope that they will get to probably also help to prevent most of these stillbirths, which are preventable. Because for the case of preeclampsia, I still believe if it is detected very early or maybe in a subsequent pregnancy, say for my case, this would be termed as a high-risk pregnancy. So I would be able to access quality healthcare throughout the next pregnancy. So that's alarming in all states.
Christine, I want to reveal the special guest. Do you want to tell everybody what happened the other day? Because we were getting ready for this session and you tell the story because I was surprised and it was a wonderful surprise. Because we added somebody to this. We added somebody to this conversation who wasn't planning on being in this conversation. And I was looking at the top of the Zoom lineup and I said, who's Diana? Who is she? Hello, Diana. Who are you? Who is Diana? You didn't come to the Zoom chat when we were getting ready for this chat by yourself. Can you explain who Diana is? And then she will magically appear in this conversation as well. Tell me who Diana is.
Okay, Diana is a consultant with a Still a Mom. During my loss and my grief session, I reached out to Still a Mom for professional counseling, and she's become quite handy in the whole process. And she's been my walk through the whole journey, and we've kept communication. So she's a very major support system in my life.
So even when you're prepping for a session, Diana was there on the Zoom meeting. Diana, reveal yourself. We need to talk about what it is that you're doing. Diana, make your microphone live, unveil yourself. You are our special surprise guest. And this speaks to the care and support and pushing away the stigma of what a stillbirth means. Tell us about your job. Tell us what you do.
Thank you so much, Femi. Thank you so much. I'm so humbled to be here today and honored, even with a last minute surprise. I'm a grief psychologist from Kenya. I work with Still a Mom. Still a Mom is a non-profit where we focus on offering bereavement support for families dealing with miscarriages, stillbirth, and infant death. So we have journeyed with over 3,000 families from 2015, where we offer professional psychotherapy services to these families uniquely for bereavement, grief, and trauma.
Diana, this question came in from Francine, who is watching right now. Please also remember the burden of stillbirths on fathers. Another leverage to underline that every mother and father should have a chance of a healthy newborn. So were you working with, and do you work with the entire family? How does that operate? Are you thinking about the mother, obviously, but are you thinking about the father, the kids? Christine was saying, no, we're waiting for this new little baby that didn't turn up.
Yes, we work with dads as much as the name of the organization is Still a Mom, but it's an inclusive organization. We work with fathers, and remember, most of the time fathers tend to be forgotten because they feel like they do not grieve, but they grieve in a different way. So we involve dads in our groups where they get to accompany their wives for couple therapy sessions and even for support groups for the men, just to address grief in their own way of grieving and to be involved with the family. Because most of the time when a family loses a baby, the father gets into the protective role. You know, they have to plan for this burial or the funeral or to make calls, logistics and all that. And they mask in their pain, they mask the grief, and it takes time. And in the long run, they're affected psychologically, and they want to be able to offer the best support for the family. So we do include that in our support systems.
Christine, I have a question for you. It's from Anchor. What are the parents' main ask of the healthcare system? What do you think the system should prioritize going through what you went through?
Okay, unfortunately on my case, I want to report I had a very good gyna and she's come through still, because throughout the whole birth process, the labor process, and also the after loss, she's become so handy. However, when it comes to like such cases of maybe high blood pressure or any other condition that would trigger maybe a stillbirth or maybe some high risk pregnancies, I wish for the healthcare one, it should be affordable to all moms. The quality healthcare should be affordable to all moms. And also there should be such an awareness that should be created to all moms, because sometimes maybe in Africa, maybe due to lack of the information, many moms will go through the whole antenatal process without at least getting the 4 or more antenatal visits. So I think there should be an awareness to all moms. Yes.
Christine, your grief is still fresh.
Fresh.
Last year you were expecting a baby and then your baby passed away. Why would you talk in a session like this to people who are trying to prevent stillbirths? What drives you to do this?
One, for me, talking about it is also therapy for me. It's a way of healing. That's one. Number two, I think we have had the stillbirth encounters so silent and nobody is willing to talk about it. So trying to share my experience also gives hope to the moms who've gone through the whole situation, or rather who've gone through the same issue, to at least gain courage that they are not alone. I would want to say when my baby died, I thought I was the only mom who has had their baby die. But when I came in for the therapy session and the professional help, I realized I was not alone. So reaching out also to other moms and speaking it publicly just helps somebody else who's been suffering or rather who is going through the same thing.
Christina, I really appreciate that. Diana as well. I'm going to bring in two midwives who've also lost children. And it's a different perspective that they're bringing, but an important one. Isti, unmute yourself. Hilma, unmute yourself. Isti, first of all, what struck you about the conversation that I just had with Christine and Diana from a midwife's perspective?
Yes, so yeah, from a midwife perspective, so I also have experience when my patient have stillbirth as well, and so this experience teach me like two important things. The first thing, sometimes in the stillbirth, there are many factors that influence the stillbirth, not just delay or not just the availability of the health facility, but sometimes it's other factors who influencing the system, the health system. Yeah, so yeah, that's the one thing. And then the second thing, as a midwife, there's this terrible feeling as a midwife when a baby dies. We feel responsible, sometimes we feel guilty. There's all these fears about investigation that will conduct by district health office and medical profession. So instead of staying with mother, most midwives keep themselves busy with other things. In my opinion, midwife need to understand this is a hard time for the parents. By spending your time to approach parents with empathetic manner, actively listening to the parents will help the midwife to understand their feelings and able to foster communication and trusting relationship with the bereaved parents. Yeah, this support may help parents with their loss, actually. Yeah.
This conversation, this session is all about ending preventable stillbirths and a renewed call for collective action. So we're talking to lots of different people, midwives, parents who've lost their child, doctors. We're going to be talking to country representatives as well. What's really important is that this session is in all of the United Nations languages. I know you've been asking about that. So you see that little globe at the bottom of your Zoom screen. It says interpretation. Click on that and it will give you one of the UN languages. So you can hear it in multiple languages and not just in English. I also want to point your attention to the chat box because Akindoyin, who is a parent who lost her child, we cannot hear her, unfortunately. We have connectivity issues. She is writing her story in the chat. Please read it. Please acknowledge it, because it is really worthwhile. So multiple ways we are getting these stories to you. Hilma is in Namibia. Hilma, you've lost a baby as a midwife through stillbirth. What is that like from a midwife's perspective?
Hello, Femi. Can you hear me? Yes.
Yes.
I would like to. Yes, I would just like to clarify. I have not lost a baby myself, but I've been taking care of mummies who have lost the babies as a midwife, and that is where my experience is coming through. I think from the statistics we have heard very well that a burden of stillbirth actually is in the African continent, especially in the sub-Saharan Africa, and most of these deaths are preventable. And I think here, listening to the statistic, for me, it's actually putting a midwife at the center. If you look into what was just presented by my other panelists, it's actually a clear call to action to focus on midwifery services, because we are the ones who are always with women, and we're the one actually who are offering these essential services that women need. My fellow midwife has also alluded it, how important is it for midwives, because this loss is not only devastating the women, but it's also a tragedy or traumatic event for midwives. So I think looking into the causes, mostly women may lose their babies because of poor quality of care, and if we draw our attention into the improvement of quality of care offered by midwives, I think this is going to actually help us end these preventable deaths. I also think want to again add to what is said already. but very clearly there is evidence that when, the focus is put into midwives to provide that continuous care, we are likely to improve the outcome.
I want to address this point that Christine made very clear, and I understand also as being a Nigerian, is that there's certain, actually it doesn't even matter if you're Nigerian or from the African continent or not, it happens in many cultures. This embarrassment, this is bad. This is bad karma. Something has terrible happened to you. You did something bad. Akindoyin was saying that. She said that as she shared her story. Maybe it was something that I did something wrong. How do you combat that? That is, I was going to say thousands of years, but that is all of our culture, cultural history telling us that something awful is connected to stillbirths. How do you get past that taboo? Hilma, I realize I'm asking you a giant question, but you're practicing on the continent, so it's really interesting to hear your take.
You see, we in general, pregnancy and childbirth is really associated with cultural practices, and unless we listen to the voices of women to understand what is data. And again, in the region, we don't have enough data to support that, because even though we do have the targets set for newborns or stillbirths, we do not have good quality of data to support this. So I think in part of call to action is a very good area that we have to explore, that we also lost, so that we are able to help them. But as midwives, we connect with women through the pregnancy. We do get to understand them, and mostly women are so free to express them through midwives, and then we connect them with the relevant resources. I was willing to hear from Christine whether Still a Mom was an initiative that she was introduced to through a midwife or through probably healthcare services, which is actually central to our role.
Oh, that's a good question. Christine.
Okay, the Still a Mom was introduced to me. It was during one of my, through a referral. It was a referral. Yes, from a friend.
I want to go back to Isti, again, speaking as a midwife, because a lot of this conversation is very sobering. Christine and Akindoyin, a lot of people are saying thank you for sharing your story. They really appreciate that you are grieving and yet sharing and hoping to help other parents. So they're saying condolences and thank you very much. Isti, is there a positive part of this conversation? What can we learn, and what are midwives doing to make this situation of preventable stillbirths so that we lower the stats, lower the numbers, lower the families that are grieving for lost babies? What would you recommend that midwives do and can do?
Yeah, so from midwife as health workers who providing the maternal services, so we need to improve our quality of care when we provide the quality of care. Yeah, because stillbirth actually is preventable. Some stillbirth occur due to poor quality in the health facility as well. Even some occur due to delays in seeking quality care. But this delay can be influenced by many things like culture, family decision making, and sometimes financial problems. So some midwife some can have role on this part too, like with culture, like provide health information for them, like encourage the mother to raise awareness, to check the pregnancy, things like that. I think by removing all these barriers, stillbirth can be avoided. Yeah, so that's from midwives perspective. And maybe one more thing that because I work with Cipaygo in Indonesia, my experience with stillbirth actually encouraged me to join with Cipaygo in Indonesia, because to improve maternal and newborn care, we need a comprehensive system approach, like I realized that. And so not just prepare the facility, but also strengthen other factors which influence the system. So when I joined with Cepaigo, I can work with Government of Indonesia in improving maternal and newborn care through innovative solutions. So the health system strengthening is very important as well.
Diana, let me bring you back into the conversation. So do unmute yourself so that you can speak to us. So Dr. Ghosh says that counselling support to families is of vital importance. Much earlier on during the Q&A session, I was also talking about supporting parents, and that was something that you responded to in the chat. Where are we now with this idea of the parents need to be supported, that it's not just, okay, they had a tragic stillbirth and there's no support for them. Do you think that this idea of grief counselling is taking off globally?
Well, I believe grief counseling is now taking shape, and I'll start to speak from my context in Kenya, in Africa, because I come from a culture whereby therapy hasn't been taken as something important for so long. But you realize 30% of stillbirths end up in emotional problems. They end up in adjustment problems because losing a baby is a very traumatic experience, and 30% of these cases are and end up being diagnosed with anxiety, depression, and also post-traumatic stress syndrome. So we are doing well, but there is the need to do more to create awareness about the importance of support. Right, even at the moment when a mother loses a baby at the hospital, and this I'll throw it back to the healthcare, the medical professionals, how do they break that information? Because that also affects their healing process. It affects how they're able to deal with the trauma. So there is the need to engage grief therapy right at the hospital, even to the family and friends. How do they communicate? How do they offer support to this person? And the need to call them out and to do an assessment, come back for a session after 3 months and to see how are you coping? How are you able to resume normalcy even in this new reality that baby is normal?
I want to say also, because Akindoyin, people are talking to you in the chat section, so thank you for being in the conversation, although we can't hear your voice. You have a midwife who is supporting you, Idowo Adelabu, so you have that support, that grief counselling as well. There's something that's come up in the chat, Christine, and even in a conversation about stillbirths. This is a hard thing for me to ask you, so if you don't want to answer it, that's okay. That talking about, did you get to see your angel, your baby?
Yes, I did.
Okay. And
Yeah.
what difference does that make? Can you talk to us about that?
Definitely. I think it was important to see the baby because, of course, having gone through the whole labor and delivery process, of course, all along I knew it was a stillbirth after the ultrasound and all that. But it's not usually a closure moment, but it's essential for the mom to see the baby and also be able to grieve throughout the whole session, I think, normally. I think that helps the whole grief process.
You know, it hurts just listening to this. I'm not even sure how you're managing to talk and share this information. When you talk to other mothers who are in the same situation as you, where you have this shared experience, what do you talk about?
Okay, for the moms, it's different for many of the moms. It depends on the cost of the maybe miscarriage, stillbirth, or whatever happened with the baby. But the overall, I think, approach towards this is giving hope. One is giving hope and telling the moms, you're still a mom, despite that you had a stillbirth. We need to recognize you as a mom. Secondly, we also need to empower these moms because also you can be sure what trickles down after the grief and the loss. Most of the moms go through the depression state. It also affects their health, even their productivity. So the only thing we need to really uphold, much as we want to demystify this taboo, we also need to give these moms hope and also walk with them the journey, even for trying to conceive or even coming to terms with the whole idea.
How are your other kids doing? How's the family doing?
The family is doing well. We are fine by the grace of God.
Do you remember the first time that you, after your baby passed, that you were able to experience joy or happiness? Or is that always with you, this child that you never were able to bring up?
It's usually a process, because for me, immediately I went into a denial stage. I think I got stuck at the denial stage for quite a long time. And then by and by, I think after 2 or 3 months, I was able now to come around about the whole guilt. Or we always, as a mom, you will want to almost as in blame yourself for whatever happened. But once you do your analytical, just analyze the whole story, at least you get one thing that keeps you moving. One, you're still alive. God spared you through the whole process. You can be sure high blood pressure, it can be silent, can be a silent killer. So in the midst of all this trauma and grief, you still have something to be grateful to God for. So at least you come back to your real self and start enjoying life, but on a slow mode, not that immediately on a slow mode.
You should go and look at the chat, because there is a lot of love and respect and admiration for you, Christine, right there. And also Akindoyin as well. We really appreciate you. I am just going to ask Diana and Isti and Hilma for one sentence, one last thought that you want to leave this session with for people. That's Christine, you've told us so much. You shared your experience, you shared your heart with us. Appreciate that. Isti, if you had one sentence to leave our audience with, what would you tell them? They're on a mission, we're on a mission, so that there aren't parents like Christine and there aren't parents like Akindoyin. Isti, go ahead. Unmute yourself.
Yes, maybe actually as midwife, I want you as a bereaved parents need to be strong, because midwife, me as a midwife will stay with you together in this. Yeah. So, yeah.
Thank you. Hilma, what's the last words that you want to share with our audience?
Thank you very much. I think from the presentation, the burden of stillbirth is known. What is needed is action, and midwifery are at the center. And we are not only here to support the mummies with better outcome, the mummies who are going through this trauma, we are with them. We will offer them our support. And again, at the same time, calling for support for midwives also in order for us to render the care that the mummies need.
Thank you. And Diana, this a beautiful surprise guest who I wasn't expecting to be in the conversation, who was there by Christine's side, even during a briefing. What would be your final words for our session today? Go ahead.
Thank you, Femi. I really appreciate that. My final words would be, let's be supportive of bereaved families, right from the medical fraternity to the families and friends. Let's be sensitive with what we say in the name of support. And to all bereaved families, it's okay to grieve. It's okay to come out and be vulnerable, for you to find help through counseling and through therapy, to find a way to navigate the new reality. But there is hope, there is help.
Diana, Hilma, Isti, Christine, Akindoyin, thank you very much for talking to us about grieving stillbirths and maybe how we take that grief and move forward. Really appreciate you. Our conversation today, there's two parts. The second part is a renewed call to action, ending preventable stillbirths, but a renewed call to action. This is why we wanted to bring in country reps from around the world, talking about where they are with stillbirths, and also that idea of collective action, that around the world, action is happening. We are doing this in alphabetical order, so we don't have any favorites. So I'm going to go first to Australia via Dr. Katie Allen. Dr. Allen, would you introduce yourself? to our audience, because I know one of the things that you want to talk about, or the thing you want to talk about, is how stillbirths are prevalent amongst vulnerable parts of our society, our community, the population. But first of all, Katie, introduce yourself. Go ahead.
Thank you very much. And thank you to the organisers. I'm very, very delighted to represent Australia as a member of the Parliament here in Australia. And I'd like to acknowledge the traditional owners of the land on which we meet and pay our respects to elders past, present and emerging, and in particular to any elders who are joining us today. I extend my sympathies to the families who've lost a baby or babies through stillbirth as well, and thank the Executive Director of UNICEF, Ms. Henrietta Ford, as well as the WHO for their comments tonight. In Australia, we do obviously regard stillbirth as a terrible tragedy, and one that affects the families as well as the woman herself, and as you mentioned before, the carers themselves. But in Australia, we are investing significant funding to firstly bring down stillbirths. We have 6 stillbirths each year in Australia, each day in Australia, and it's affecting 2,000 families each year. But despite the evidence that there are many stillbirths in Australia that can be prevented, we haven't been able to drop the rates of our stillbirth over the last 2 decades. So there's been renewed calls for increasing funding to support prevention of stillbirths. And I'd like to congratulate those stakeholders in Australia, including the Stillbirth Centre for Research Excellence, led by Professor Vicky Flenady, and Red Nose, Still Aware, and Stillbirth Foundation Australia and SANS. And these are all very, very good organisations that are working in a very dedicated way to help with stillbirths. But it is worth mentioning with listeners who are on today's call that in Australia we have an Indigenous population that are not doing as well as the non-Indigenous population. So our Aboriginals and Torres Strait Islanders have a lot of health inequities, and that health inequity is also showing up in our stillbirths, with almost twice as many stillbirths per 1,000 in those who are from an Indigenous background. And we know that all the same causes that are causing stillbirth right across the world are problems for those in Australia. So that includes increased rates of diabetes and smoking, but also infections such as hepatitis C, HIV, and also the fact that many of our Indigenous population live in a rural and remote location, so have difficulty accessing good health care, good prenatal care, and of course, good birthing assistance. So in order to help reduce stillbirth in Australia, the Australian government is investing a range of initiatives to support families, and these include development, which is a very exciting initiative for our country, of a national stillbirth action and implementation plan. And we also have funding for a national implementation of the Safer Baby Bundle, which is an initiative to reduce stillbirths led by our Centre of Research Excellence. We're also funding stillbirth education and awareness campaigns, funding support services for families affected by stillbirth, and funding for stillbirth research and data collection. And I really commend the meeting today in that we all need to work together to raise awareness. I think that stillbirth is a grief that can often not be spoken. And I often say, I said this in my first speech as a Member of Parliament, that there are words for our grief and our loss. There's words for orphans, there's words for widows and widowers, but there's no words for the loss of a child in the English language anyway. And I think that speaks volumes to the fact that it is such a difficult topic for mothers to talk about, and it's such a deep and painful grief. So in our action plan going forward, we have a number of close consultation with stakeholders, which of course is very important, and particularly with our Indigenous program, we want to co-design programs to make sure that we are culturally sensitive to the taboo issues that may surround how to deal with stillbirth and how to raise awareness about improving pregnancy care and making people aware of the issues around reducing stillbirth. In Australia, we also have a large group of migrant and refugee groups and also women living in rural, remote communities who are at increased risk of stillbirth. So our actions are focused on culturally safe health services, addressing language barriers, health literacy, and providing culturally appropriate bereavement care and support. And these are all included in our National Stillbirth Action and Implementation Plan, which is being worked on at the moment. Some of the activities that the Australian government is currently funding to reduce stillbirth amongst high-risk groups include translation of the Safer Baby Bundle stillbirth resources into 23 languages. Australia is a very multicultural and diverse country. We're very proud of our tolerant and diverse and multicultural communities. And so we're very pleased that that initiative has been undertaken. And I myself, as a paediatrician and a medical researcher, know of cases of quite staggering situations where women were unaware of what was going on and were unable to speak English, and very difficult in the healthcare sector to not be able to communicate, and the tragedies that befall these women who have not had the issues translated into the language in which they speak. As I said before, we're co-designing stillbirth prevention resources with Aboriginals and Torres Strait Islander people. We have webinars and resources targeted at rural and remote clinicians and families. And through COVID, as we are doing here tonight, we have put a lot of resources as an Australian government into telehealth so that we can access, or people who live remotely and all across the globe now can access good healthcare via telehealth or by video and by telephone. And that's, I think, a very valuable resource that as a government, we're very proud to have increased this resource to make healthcare more equitable right across our wide continent, Australia. So I'd just like to conclude by saying thank you to all of you for the opportunity to share with you what Australia is doing to reduce stillbirths and support families impacted by stillbirth. And I hope that in the future, fewer women and their families will experience the devastating impact of stillbirth. Thank you.
Thank you very much, Dr. Allen. If you could say, Dr. Bim Singh Tinkari, just mute yourself just for a second. I have a quick follow-up for Dr. Allen. Dr. Allen, if there was this, that was a very impressive list. If there was one thing that you knew that is working, what would you share? Because we're also looking at best practices. Dr. Tinkari, please mute yourself. Fantastic. Thank you very much. One thing that you knew is like, actually, this is an example that I would love to share with my colleagues elsewhere around the world. What would it be?
Well, I think that the most important thing is antenatal care. And so I really do congratulate that in order to reduce stillbirths to that wonderful target that this group is working towards of less than 12 per thousand, I think a regular and antenatal care, universal coverage of antenatal care is so incredibly important. Women should not be left alone to deal with the difficulties of pregnancy and labour, and that they should get good maternal care, and that in a language they understand, in a culturally acceptable way. So good access to healthcare has to be a #1 priority right across the globe. And we should all support that, so every woman has good antenatal care, regular visits, so that any risk factors that are identified can be treated early and therefore impact the prevention of a tragedy that could be prevented.
Dr. Allen, we really appreciate you. Thank you very much. We go from Australia to Nepal. We had a little preview there from Dr. Tinkari. And if you've been in the chat, you would have seen Dr. Tinkari being very engaged and active in the chat. Dr. Tinkari, in Nepal, please unmute yourself now. We'd love to hear from you. And also make your video viewable so that I can hand over to you to tell us about, oh my goodness, this is the elephant in the room. Dr. Tedros mentioned COVID. How COVID was maybe snatching back some of the progress that has been made over the last 20 years with preventable stillbirths. You are going to talk about COVID-19 in Nepal and the impact it's having on stillbirths. Dr. Tinkari, over to you.
Okay, thank you, Femi, for your excellent work. And we so far the Nepal is concerned, we have made a tremendous progress for the maternal child health, but because of COVID, we have a lot of problem here. And I just want to say that I was hearing that what the midwife are contributing in the different parts of the world is really appreciating for us. And we have a problem there. We have a limited number of midwives here in the country, and so far we have achieved tremendous achievement in maternal child health, and we have achieved the MDG goal, and we are way far for the SDG goal also. And this because of COVID, we had made a different assessment in the initial stage and the second stage also, and impact assessment we conducted so far. I don't need to tell the whole data about this, what is the impact, but we have put our effort to make our non-COVID activities to go ahead. So we have made a lot of progress on that, and we are putting our effort. And because of this COVID around the world, lack of PPE, and because of fear and everything is hampered, bit hampered. But we are putting our effort to make it go ahead. And so far the stillbirth is concerned. When you compare with the 6-month data of last year and this year, that has gone up. That has gone up, but we have to put all our effort on that. And whatever the midwife they are putting the effort, we don't have in Nepal also. So we have to focus on the midwife, what they have contributed on that effort. That's really important. And even the global community and WHO is focusing on that. Stillbirth attendance is not it's the absolute one, but we can't avoid that one. That is important. And so far, what I've raised the issue on that regarding this. What is the evidence? Which country has produced? What is the evidence? We can replicate on that. Okay, country Nepal can replicate on that. What is the evidence? We just wanted to hear on here. But as for the presenter, they have presented, and they mentioned that this country has made a tremendous progress on that particular area. So what is the innovation? Just we want to know. If there is additional innovation, what Nepal is not following, so we want to replicate that pattern. And this is the process. This is the meeting. This is the renewal of what the collective commitment we have done. What we have done. What was the commitment we have done in the World Health Assembly, and what we have achieved? That has to be spelled out here. That is the main thing. What I want to say this commitment made and achievement has to be spelled out on the particular point.
Dr. Tinkery, I have a question for you. This is from Susanna Leisha. Susanna says, fear is a key factor in reducing access to antenatal care in COVID. How do you address that?
So far, antenatal access is concerned, initially in the lockdown state, we have a disturbance in the antenatal access, delivery, interpretation, everything we have a disturbance, even including immunization. And we made the initial assessment with the support of UNFP, and that indicator maybe that's a global, that has gone all around the world. And after we requested what we made the intervention after 4 months, that has come up and that's improved. So we wanted to say that when you compare with the initial lockdown stage and whatever the basic health service government is wants to provide, that has improved, but not to the level what we had expected. What was in the initial last year, that was the difference. But main issue is that fear and lack of this PP is the major issue, and that even the partners and even no one is going to address on that. That is a big issue on that. PP is the most important part.
Yeah.
And if the PP is available for health workers, they want to go for fight. That is the issue. And that is one of the most important part. And we have made a significant improvement in all the areas. So far, Stillbirth is concerned, that this what we made the commitment is the most important part. And commitment has to fulfill. Who has made the commitment? Dr. Tinkari has not made the commitment. Maybe the commitment has once made, that has to fulfill, and that has to go on the line. That is a very important part, And whatever the midwives, they have presented everything, that is important part, and that is the ultimate part to go in the very far region of our country. They will contribute. That's important part. That's why.
Dr. Tinkery, thank you so much. I really appreciate the fact that from the moment we started this conversation, you were in it, deep into the conversation, and I appreciate your engagement and your commitment. And thank you for telling us about COVID-19 and the impact it's having on stillbirths in Nepal. Really appreciate you. So there's one more country that I want to take you to, and that is Nigeria. You may remember that the Minister of Health for Nigeria gave his opening remarks at the beginning of our session, and he was very honest about where Nigeria was. Number 2 in the number of stillbirths, the highest number in the world. I want to bring in Dr. Salma Ibrahim Anas Kolo. Doctor, can you help us out with understanding what your challenges are in Nigeria? Because your preventable stillbirths are so high compared to the rest of the world. Dr. Salma, please unmute yourself and introduce yourself. Go ahead.
All right. Thank you, Femi, and thanks to all the organizers of this very important conference focusing on the stillbirth and the opportunity given to Nigeria to share our own thoughts about the challenges. It is true, we have one of the highest burden, the second globally, and we're really worried about it. And we have looked into what major challenges. So major challenges are around even access to quality healthcare services, access around women having access to antenatal care and skilled birth delivery. We still stand very low. When you look at most of our women deliver at home, over 60%, and most of the stillbirths automatically happens at home because most women deliver at home. And then, even when they deliver in facilities, very few of them. Yesterday, we have a verbal autopsy and social autopsy report that was reported based on 2018 NDHS, National Demographic Health Survey. And we found that most of women, less than 19%.
Dr. Salma, please continue.
All right, can I continue, please? Yeah. So most of these days, even those few women that are able to make it, about 19%, maybe less than 3% have access to the services. So these are some of it around the health system issues and quality of care. Then the major issue also that came out clearly from our verbal autopsy report was about beliefs, such cultural beliefs. The culture of most Nigerians are that they don't consider stillbirth as humans, as babies. So, and then they don't even report it. And even when it happens, in most of our facilities, they are not recorded. When we look in depth with the National Population Commission that are responsible for registration of births and dates, they don't record most of stillbirth because it's not considered. And then the issue of taboo around it. Many women also are ashamed to report that they've lost a baby that is not live baby. So because of taboo, it's a common practice that most women are not even condoled after the loss of such babies around that time because they are not considered as human. So these are some of the challenges, but most importantly also we have challenges about women accessing services due to distance, very far from where they live, and also transport system, emergency transport systems are mostly not available to help them. And then delays around decisions because the norm in the country is mostly decisions are taken by the partners, the husbands. So sometimes there are delays around that. So these are some of it. And then capacity issues also of reporting information about stillbirth in Nigeria. But what also we found, even where the services are available, a lot of people have lost confidence in the health systems because of the limited number of human resources for health that are available to provide the services. So over time, a lot of women prefer to have their babies at home without supervision by skilled birth attendants. So these are really causes for concern. And as you are aware, Nigeria is one of the countries at the moment that is going through severe security challenges. So because of the insecurity also, it is another barrier that deter women and caregivers from accessing services, even where such services are available. And I will not end it without also reiterating another big challenge is about education. The minister mentioned it this morning. Maternal education is a key to improving access to services and also improving access where they will be able to pay out of pocket. So there are numerous challenges, but this is just to share a few of them.
There are Nigerians in the chat, Dr. Salma, and Nigerians are basically just did what I did, which is sigh, because the list of challenges can go on and on and on. So in that vein, what would best practices be? What is practical where you can say to women, to the limited amount of healthcare, to the doctors who have stayed in Nigeria, how do we help? How can we help?
Well, we've done something that has worked in Nigeria, and that is polio eradication. And it is health workers, managers, policy workers, makers that come together, including leaders at community level, religious and traditional leaders. So they put their heads together and find a way of eradicating polio. And this is, I think, one of the best practices we have in the country. This is one of the best lessons we have learned. And currently, the Honorable Minister of Health, with support, just about 2 weeks ago, launched a huge platform, a platform around the thematic areas of reproductive, maternal, newborn, and child health, including the elderly and nutrition, to bring all partners around, including the traditional institutions, so that we use what has worked best in Nigeria to leverage all the resources that are available to strengthen our health system. But also, most importantly, part of that platform is to see how do we focus on social and behavior change, because a huge part of our areas of concerns and challenges are around culture and religious belief that deter access to services. So there's this robust platform as part of that effort to ensure that how do we reach communities with the right information to change their attitudes, to change their behaviors, to improve uptake of services. At the same time, also working on them on the service delivery side to change attitudes of health workers, good behaviors, that will also allow women to obtain and access such services. So these are some of the best practices that we have learned, and we are trying to put it together. We've had a newborn action plan, which is between 2015 to 2020, and we are currently working on this new action plan. So what part of what we have learned, also keying in lessons from the COVID pandemic, the impact of the COVID on disruption of services, especially essential services, which has also worsened the situation of stillbirths in Nigeria, as well as newborns. So all these efforts are ongoing together, and then increase, focus on data generation, recording of stillbirths, and also reporting. So we are collaborating very effectively with one of the key partners, which is also part of the platform that was launched, the multi-stakeholder platform, and that is the National Population Commission and also the National Bureau of Statistics, to see how we can build capacities around that.
Dr. Salma, it is so encouraging to hear not just the awful statistic of Nigeria being number 2 in the world for stillbirths, but hearing the long list of initiatives that are put together to try and address this. I will be looking with great interest to see how you fare over the next few years and by 2030. Thank you so much for joining us today. Really appreciate you.
You're welcome.
Thank you. It is obvious from hearing from these different voices in our preventing stillbirths moving forward that donors are going to be really helpful, really important. For instance, you're about to hear from 2 donors who have both funded the stillbirth estimation work. So we even know that Nigeria is number 2 as far as preventable stillbirths are concerned. We know where all the countries are. We can keep track of them, so we know how do we do better. I want to bring in Dr. Amy Pollack. She is from the Bill and Melinda Gates Foundation, and she's going to tell us what that foundation is doing regarding its stillbirths focus. Dr. Amy Pollack, good to see you. Welcome.
Good morning, Femi. Thank you for doing such a good job managing such a significant panel and dialogue. I just want to point out that personally, I trained as an obstetrician and practiced. I really know what it feels like to be in the room with a catastrophe, an obstetrical catastrophe. And I want to acknowledge the courage of the women in the room who've helped remind us that this is about so much more than just numbers that we see in this remarkable UN-IGME report that's come out to help us announce to the world and codify the problem that we have with measuring, documenting, and dealing with the problem of stillbirth. So on that note, I also want to thank Drs. Hereward and Banerjee for characterizing the shroud of unknowing.
Amy, Amy, can I
yes.
just ask you, we only see your name, we don't see you. Are you
I'm
about
sorry.
to show some slides, or are you doing this incognito?
No, I meant to be incognito.
Yeah, there you go. All right, fantastic. All right, so this
sorry.
We are talking about engagement with partners. Yeah, we'll do a little spell check there. This again is Dr. Amy Pollack, and really good, literally very good to see you, Dr. Amy. Take it away again.
So sorry, could you hear me speaking, Femi?
Absolutely.
Okay.
We just didn't see you. And now
I just don't want to repeat myself.
No need to repeat yourself. To continue.
So I was talking about this, Dr. Hereward used the term, the shroud of unknowing. And I think this really is striking to me because I think that unknowing has been like a wall that separates the individual women from the problem of their care and their grief and the healthcare system from accountability. And so I think documenting and pulling down that wall has been really critical as we move forward in our commitment to the information that's in the first ever UN-IGME Global Burden of Disease on Stillbirth report. And the foundation has played a role in this all along in trying to drive and help our partners drive forward the partnership that created this incredible report. The Gates Foundation is very committed to improving our global understanding of measurement of stillbirths. We do that in country, but we're particularly interested in the timing of stillbirths to better understand the etiology or cause of stillbirth. The measurement and documentation of whether a stillbirth is fresh, in other words, happens at the time of delivery, or macerated, which happened during antenatal care sometime in the past, tells us whether we have a problem with care during labor and delivery or during ANC. And those causes can include, of course, untreated infections and even malnutrition. These are indicators of a failed system, all of them. And that's why we're so interested in the numbers, because we need to make our voices heard. We need to drive policy and change in quality of care for mothers and for babies together as a dyad. So we're working on that in a number of ways. Not only are we working on the measurement of the problem and documenting it so that we can use evidence to speak to policymakers at a national and subnational level, but we're also committed to developing and testing new life-saving interventions, hoping that these interventions will help democratize care or make it easier for every level of the system to provide good care and improve coverage and quality, both in the antenatal period, the intrapartum period, and postnatal care. We're working on improving the quality of institutional deliveries and skilled birth attendants. We all recognize the problem of safe delivery at home. I think Dr. Sama points to this in Nigeria, where we have a huge percentage of deliveries that still occur at home, many of them without a skilled birth attendants. And recent reports, the work of Dr. Margaret Crook indicate to us that we need to look at the health system in particular and figure out how to help women get to and have access to skilled providers. We're interested in intrapartum monitoring for every woman and her baby so that we know when an intervention is appropriate. Investing in health service redesign to strengthen the networks of care that safely manage intrapartum complications by ensuring the right provider with the right skills and highly functional at the right level of care. And of course, in strengthening midwifery as an accredited profession. And we will have a huge drive towards that in the next couple of years. Lastly, we're focusing on some of the indirects. Things like improving linkages with maternal nutrition and anemia prevention. We're only beginning to understand the impact of anemia on women in their lives. If they come as a baseline to their first pregnancy, having been bleeding monthly for a long period of time, and a lack of nutrition that supports adequate iron stores to feed both the mom and baby, we know that this leads to a neurologic deficit in the baby for the long term. And so we need to get to those root causes and help the mother come to the delivery in a safer way physiologically and in an institution that can care for her properly. And we're really interested in increasing access to comprehensive family planning services. We all know that women who space their babies do much better in taking care of the baby they've had and the next baby that may be coming. And so we're committed to this entire picture and the life cycle of women, trying to acknowledge the need to have the healthiest women possible that go into pregnancy and delivery in order to address the problem, both from a health system side and from a thrive side on the part of women's and babies. And I want to thank you, Femi, for giving the opportunity to talk about the work that the Foundation is doing with all of the partners that we have here today. Thank you.
Thank you very much. Really appreciate it, Dr. Pollock. I want to bring in another donor, and you may not recognize this acronym FCDO, but you will absolutely know DFID from the UK. So FCDO is the new DFID. Darren Welsh is with us to talk about what the FCDO is doing in terms of stillbirths. Darren, good to have you.
Hi, hello Femi, can you hear me?
I hear you beautifully, and we see you as well. What do you want to share with us?
Perfect. Yes, I'm the policy director at the new FCDO, bringing together our development and our diplomatic expertise into a new merged department, and I'm responsible for our work on global health, amongst some other things. I mean, this has been a fantastic session, so thank you so much for the way you've steered us through this really tricky set of issues, and the panelists and participants have just been amazing. It's been such a powerful set of interventions, and particularly moving testimony from Christine Akindoyin. So, you know, a big thank you to them. I mean, we welcome this report, which we have been closely associated with, and the way it's shining a light on this really important issue, and also putting on the table some really concrete suggestions and targets and things we can all rally around. I mean, nobody can fail to be struck by the enormity of the challenge, and that was set out very clearly by Mark at the beginning. One stillbirth every 16 seconds. That's really shocking, and equally shocking the fact that stillbirths are more than 7 times more likely in low-income countries. There's a real injustice in that. And that an additional 6.6 million lives could be saved by the SDG target of 2030 if we can close that gap. You know, this is a silent human tragedy that we've heard a lot about today, but we've got to break that silence. And we know that we can change this. And Dr. Tedros at the beginning gave us some great examples of that as well, some real successes that have been achieved. So look, the FCDO and the UK stands alongside all of you in responding to this call for action. You know, this government, the UK, made a commitment in its manifesto to work with partners to end preventable deaths of mothers, newborns and children around the world. And that commitment is going to be embedded into all of what we do on the health agenda. and reducing stillbirth rates will be a key and important element of that work. So a few things we're going to do, specifics we're going to do in response to that call for action. So first of all, we're going to continue our significant investments in low-income countries, helping them to strengthen their health systems and other drivers of health. We've spent £1.4 billion on health in 2019, and we're determined to continue working with our partners to get really great value for that and having as much impact as we can. We know that a country's stillbirth rate is a good proxy for the strength of the health system and the quality of care, and it's shocking that 40% of stillbirths occur after the onset of labour. And Dr. Anshu, I thought, very helpfully pointed out the system's weaknesses and the importance of getting basic healthcare systems in a much better place. I also want to just pick up a point about midwives. They're really central to this agenda. And this, of course, is the year of the nurse and the midwife. And I want to applaud the work that midwives do and the range of skills and care that they provide in very difficult circumstances. We have recently announced a new UK Partnerships for Health Systems programme, which is going to support nurses and midwives and build connections across the world. £5 million of that investment is going to support the active participation of midwives, linking institutions here in the UK with institutions overseas. So we know that we also need to tackle the underlying factors that contribute to stillbirths, making sure that mothers arrive at the point of giving birth in the best physical shape they can be in. And nutrition, we believe, is a key factor in optimizing maternal health. And this was mentioned as well by the Honourable Nigerian Minister for Health. Since 2015, the UK has reached 55 million women and children with nutrition support around the world through our investments. And that's going to continue to be an important part of what we do. And our country programmes all around the world have been pivoting to try to make an impact on this issue, particularly in the light of COVID. I should just say a word about that. We are making our programmes work harder in partnership with governments to mitigate the impact of COVID-19. Our programmes are responding to that situation around the world. In Nepal, for example, which we heard from earlier, we're supporting the national response to COVID-19 and helping that country and others to support their essential services, including maternity care. The final thing I want to mention is to just come back to this point about stigma and misconceptions. I think that's really important, and the mental health dimensions. The mental health impact for those experiencing tragic loss of stillbirth has been highlighted in the report. We've recently published a new position paper and theory of change, which outlines our commitment to taking a really comprehensive and rights-based approach on mental health. So that's just a few things we're going to do. I think it's been an enormously important event. Thank you so much. And I can assure you that the FCDO will be standing with you on this renewed call to collective action. And the actions are set out very well in the plan. We're looking forward to working in partnership to make a real difference on this issue. Thank you so much.
Thank you very much, Darren Welsh, being part of a renewed call for collective action as far as reducing the number of preventable stillbirths. That call to action, we're going to make it explicit with Lue Pearson from UNICEF. Lue, over to you.
Femi, I'm trying to show a few pictures by sharing my screen.
If you have sharing permission, you can go ahead and do it. We will find out. Aha, all right, put it in play. There you go, fantastic.
Femi, first of all, my apologies. There are many Lue Pearson lockdown today. I think it is because I forwarded the calendar to my colleagues and due to a technical error. And I'm sorry for the confusion. And I want to share my reflections through 3 pictures, what I saw in the field in 2019. The first is the importance of vital registration and statistics, birth and death registration. When I was in DR Congo on a Saturday morning, I visited a health facility. And this lady was doing birth registration. She has the book and everything she copies 4 times. This is every birth of the baby took place that week. And I asked her, why does she have to write it 4 times? She said, well, one goes to the family, one stay with the health facility, and one goes to the government, and one goes to the somewhere else. And I said, can I help you? You're writing so much, page after page. She said, no, you can't do it. You're going to make mistakes. I'm very well trained. I will make sure everything is correct. But she agreed that if we can help her to digitalize the system the job will be easier. So getting the information out, get every birth and death registered. Second is to return and invest more in the basics. In health facilities in developing countries, this particular case, a health facility in DRC also, is under great expansion. They're connecting water from the roof, collecting rainwater, expand crowded maternity to improve quality of care. I don't think we need to wait for silver bullets. The government and all of us can do more to make the basics work better for mothers, for families, as well as for healthcare providers. And for us, the international community, to bring maternal and newborn health program closer together, break the silos. Stillbirth calls us to work even more closely. This is just my experience, simply shared with the 3 photos, not to lose hope, and we can do a lot today. Thank you.
Thank you very much, Lu-Wei, Dr. Lu-Wei Pearson. I want to close this session with the Executive Director of UNICEF, Henrietta for her closing remarks. Henrietta, it's always good to have you in our conversations, particularly this one. I'm going to hand over to you.
Thank you very much, Femi, and it is a delight to see you being our moderator. There is just something about you, Femi, that just makes every session light up, and this is such an important one, so thank you very much for being with us. So let me add my good morning, good afternoon, and good evening to everyone, and on behalf of all of our friends and partners at UNICEF, thank you for being part of today's discussions. We are all deeply moved by the stories told by parents and midwives here today. They are among millions of families who lose a total of about 2 million babies each year through stillbirth, with an additional 2.4 million dying within the first month of life. In fact, by the end of today, nearly 5,400 women will suffer the loss of a stillborn baby, and another 6,700 will lose their newborns. At UNICEF, babies are a part of our work every day. We send a special message of support and solidarity to those women and families who have endured this heartbreaking tragedy. We also understand the great psychological and financial costs for women, families, and society. They are severe and they are long-lasting. At the same time, I hope we are all coming away inspired to do more to prevent stillbirths in countries around the world, and to transform these individual tragedies into collective action. The best way to honor these mothers and families who have lost so much, and to ensure that fewer and fewer families have to endure these losses each year. Because these deaths are largely preventable, with quality antenatal care, with proper monitoring and care during labor, with access to emergency obstetric care, and of course, with a skilled birth attendant. Right now, too few women are receiving this care, especially in low and middle income countries. In sub-Saharan Africa, only 6 out of 10 women have access to a skilled birth attendant. And for the region's poorest women, the number drops to 4 in 10. And as Darren Welch just said, this is a call to action. But poverty is just one barrier. Countries' health budgets do not include enough resources to address this issue. Stillbirths are still largely absent from worldwide data tracking. And so decision makers are often unaware of the problem. Stigma, taboos, discrimination also keep women from the care that they deserve. And now COVID-19 pandemic is disrupting health systems everywhere, including maternity checkups and antenatal services. These disruptions come at a huge cost. According to one study of 117 low and middle income countries, we estimate that even a 50% disruption in health services could mean an additional 200,000 stillborn babies over a 12-month period. Each loss is a personal tragedy, and worse, a preventable one. The need is urgent because the next 6 months will likely see an additional 70 million babies born around the world. And we must take action to ensure that these babies and their mothers get the care that they need. Today, UNICEF proudly joins the call for a renewed commitment to end preventable stillbirths by 2030. First, by bringing primary health services close to where women live. It can be done. UNICEF is accelerating our work in communities to build stronger health systems in the wake of the pandemic. This includes reaching millions of women and children with essential healthcare services, including antenatal, safe delivery and postnatal care, newborn care, immunizations, nutrition, treatment, and screening for common childhood illnesses. We call on governments and our partners to continue joining forces to make our dream of universal health coverage, including for pregnant mothers, a reality for every community. And second, we call on governments to summon the political will to invest in these systems over the long term. Every mother and child deserve every chance at a healthy start. Governments must prioritize universal access to high quality and timely antenatal and delivery care, not only to prevent millions of stillbirths and neonatal deaths, but to build stronger health systems overall. As countries respond to COVID-19, we urge that they also protect, preserve, and track the financial and human resources for ensuring quality care for every mother and newborn. Throughout, our partners and countries around the world can count on UNICEF to walk this path with you. Our staff members in across 190 countries are dedicated to the futures of every child and every newborn. And we're proud to join the global call to accelerate our progress towards a better future in which preventable stillbirths and neonatal deaths are a thing of the past. So thank you.
Thank you very much, Henrietta, for the Executive Director of UNICEF. And while I'm thanking Henrietta, I have to thank you. I'm going to say the community, our community. I have been watching you engage and talk back and forth in the chat section, and I know you are an engaged community on a mission. Thank you to all the speakers, the panelists who were part of today's conversation. Dr. Yacobi from Afghanistan. I know you haven't heard from Dr. Yacobi yet. That is because Dr. Yacobi took the entire 2 hours to try and get online. Dr. Yacobi, thank you for your commitment. I'm sure we will catch up with you at another event. And if you have just joined and you're wondering, where can I see 2 hours of conversation from people who are very committed to preventing stillbirths going forward, you need to go to the Quality of Care Network, their YouTube site, and you will see this entire conversation on YouTube. My name is Femi Oke. It has been my pleasure being your moderator. I will leave you with this slide with lots of information and resources and wish you every success in preventing stillbirths going forward. Thank you very much, everybody. Take care.
Thank you, Femi. Thank you, everyone.
Thank you.
ठीक है भेज देते हो तुम ऊपर